Okay, great. All right, well, everyone, good evening, and thank you for joining us tonight for tonight's educational webinar, Reverse Total Shoulder Replacement. Are you a candidate? Tonight's speaker is Dr. Scott Stevens, OrthoNeuro orthopedic shoulder and elbow surgeon. Dr. Scott Stevens is a board-certified orthopedic surgeon specializing in shoulder and elbow surgery and sports medicine. He performs all aspects of shoulder surgery, from minimally invasive arthroscopy to complex shoulder replacements. Areas of special interest include shoulder arthritis, rotator cuff, distal humerus fractures, and bicep tendon ruptures and tendonitis. Dr. Stevens will answer questions following his presentation. Please type your questions in the Q&A box at the bottom of the screen. Dr. Stevens, go ahead and take it over there. Thank you for joining us this evening.
All right. You guys all hear me? Can you hear me in there? Good. So I appreciate everybody being here on a Wednesday night. Now with the magic of Zoom, you might see a 4-year-old run naked across the screen at any point because it is close to his bedtime. So bear with me as we go through this. But my talk's going to be about reverse total shoulder replacements and are you a candidate? So, it's not. All right. So a little bit about myself. I grew up in Akron, Ohio. I went to undergrad at John Carroll University in Cleveland. I did my residency down here at the Mount Carmel system. I did 2 fellowships. One was a minimally invasive shoulder arthroscopy, where I was fortunate enough to work with the Miami Heat the year they won the world championship. And then I did a mainly shoulder arthroplasty fellowship the following year in San Antonio. We stayed in Texas for a couple of years, and then once we started having babies, we kind of drove through the night to get home to get some support from the grandparents. So, what is arthritis? Arthritis is the loss of the soft cartilage at the ends of the bone. The cartilage is what allows that smooth motion that we see when we're running on our knees, throwing with our arms. And it can result from a variety of causes, either the standard degenerative arthritis, such as osteoarthritis. Some people have an inflammatory type of arthritis, such as rheumatoid arthritis, where we have an autoimmune disorder that can cause the destruction of the cartilage. Any kind of bad trauma we have to our shoulder. If we have an infection, there's a specific type of arthritis that we see for the shoulders that we don't see in the knees and the hips is when we have one of our rotator cuff muscles, which are the muscles that help allow us to lift up our arm. If they tear and they've been torn for a long time, we can develop a specific type of arthritis known as rotator cuff arthritis. But regardless of what the cause is, the end result is loss of cartilage and bone-on-bone rubbing at the joints. And arthritis is extremely common. It's a leading cause of disability in America. It affects up to 50 million adults. And more concerning or sad is that it can affect a significant amount of children too, especially with juvenile rheumatoid arthritis. The classic symptoms can come and go. They can vary in their severity from very minor to very severe. Some of the symptoms that we see, especially patients with late stage or advanced arthritis, is chronic pain, affecting the daily activities, affecting your quality of life, and pain that can affect you at night while you're sleeping. And I'll tell you, as a shoulder surgeon, that's probably the most common complaint I have as pain at night and inability to sleep, tossing and turning. So a little bit of basics of the shoulder anatomy to give you an idea. There's 3 main bones that make up the shoulder: the humerus, or the long bone of the arm, the scapula with it, which is your wing bone in your back, as well as the clavicle. It's a ball and socket joint, meaning the humerus can rotate in the socket of the scapula. The ends of the bone are covered by the smooth cartilage, and muscles and tendons allow the stability and support of that joint. And the main muscles that we see that affect the shoulder are the rotator cuff muscles. These structures allow the shoulder to rotate through really more range of motion than any joint we have in our body, which causes the shoulder to be the most unstable joint as well. And so some of the symptoms we see with arthritis specifically, we go from the top picture, a nice, smooth, healthy appearing joint, to the bottom picture where there's kind of bone on bone arthritis. We see pain, swelling, you start losing motion in your shoulder, stiffness, catching and popping. And so the first step as an orthopedic surgeon when you come into office is we get x-rays. From those x-rays, we can see some of the classic signs of arthritis, such as losing that joint space, bone spurs developing, the bone can turn hard and white, which is called sclerosis, and actually can start eating away parts of the bone, and we see bone cysts. And if you have long-standing arthritis over decades, it can actually start rubbing away certain parts of the socket. And so the different treatment options we have, we always try to avoid surgery at first. Some of the conservative options that we have is very simply, if it hurts, don't do it. Anti-inflammatory such as ibuprofen, Aleve, Tylenol. We can try some physical therapy. We sometimes want to make sure we just don't lose any more motion, maintain as much. We don't want the therapist to kind of really crank on that arm. We just want to make sure that we can maintain what we have. If it's very mild arthritis, especially in younger patients, we'll sometimes do a minimally invasive shoulder arthroscopy where we use a camera, small shavers, and try to smooth out the joint as best as possible. It doesn't get rid of the arthritis, but sometimes it can at least delay until we need a shoulder replacement. And once we get older or we have more advanced severe arthritis and we fail conservative management, then we start looking at shoulder replacements. And unlike knees and hips, there's two types of shoulder replacements. There's an anatomic shoulder replacement, where we very simply replace the ball and socket just like it is. And if all your tendons and ligaments are intact, we can do that. But for patients who do have torn rotator cuff tendons, then sometimes we start looking at a different type of option called the reverse total shoulder, which we're going to look at a little bit later. So to start with the basics, what is a shoulder replacement? Very simply is we're taking off the ends of the bone in the socket and replacing with artificial components. We call this a prosthesis. We replace the humeral head, which is the ball, and the glenoid, which is the socket. It's extremely common procedure and becoming more common every year. There's 53,000 of these performed annually. And a study looked at the increased percentage of this procedure being done. It increased by 322% back in 2015 from 2010, showing as the implants improved and the results have improved, we've increased the number of candidates that are undergoing this procedure. So to give a kind of a brief history, it's really interesting seeing kind of where we are now, because it's nice to know where we were, especially in the early 1900s. This implant was originally designed in the late 1800s by a French surgeon, and the implants were very rudimentary, and it's for patients who had tuberculosis. And really, the implants failed miserably. They didn't do a great job of restoring motion or function, and not much happened for about 60 years. And kind of like this picture of the car stuck, we kind of got to a point to where not much progress was being made, and patients were suffering because of it. And then in the 50s and 60s, we had some very innovative surgeons that looked at the way hip replacements were being done and said, there's probably a better way of doing this. And they looked at patients who had shoulder fractures, and the problem at that point was if you had a fracture of your shoulder, it was unfortunately just lost motion, lost function, and you were kind of forced to live with it. Nowadays, we would never even consider this, but back then, getting an implant that could restore the function was revolutionary. It changed the course of someone's life, their ability to use their arm and live a pain-free life. That time they really just let it heal. And although the pain would go down, the function was pretty miserable. And they looked at total hips to do this. And when they started looking at total hips and trying to recreate the anatomy, they started having much better results. And once they started seeing positive results, the amount of implants just exploded. We have about 70 different designs to this time. And so as we've gotten to more current technology, we've seen improved technology. The goal now is to preserve as much bone as possible, so it's more minimally invasive. And with this, we've developed a modularity where we can switch pieces and parts out to get the perfect fit for each patient. And because of this, we've had excellent results. We've showed improved pain relief, better function, better range of motion, and the implants last longer. The data we have now is from 20, 25 years ago, and those implants aren't nearly as good as we have now. So our goal is to have these implants last 25 to 35 years. Patients often ask me, how long do these last? The honest answer is we don't know, because we don't have enough long-term data on these implants. But if the other ones were doing that well, we can assume that these are doing better. And once again, there's two different types of implants, the anatomic and the reverse shoulder replacement. So when you go and see the orthopedic surgeon, the first thing is they're going to do a thorough medical history. They want to know if there's any other medical comorbidities or other issues such as diabetes, other prior issues that you've had in the past. We'll do an examination looking at how much motion you have, how much strength you have, and is it stable? Does the shoulder feel like it's popping in and out of socket? We always start each initial presentation by getting x-rays to see how advanced that arthritis is. And if we start deciding that surgery is the best option, Then we start getting more advanced imaging, such as a CT scan. From that CT scan, we can do a lot of preoperative planning, such as looking at, is there any bone missing? Is the humeral head or the ball, is it in a different position than it normally should? And we can use these CT scans to put into computer programs and make a 3D model of your shoulder. From that 3D model, we can get the exact size, we can get the exact implant we're going to use, and have a better idea to restore the function as anatomic as possible. So who needs a shoulder replacement? That's a question I get from a lot of primary care doctors as well as a lot of patients. Well, the first thing, it should be severe shoulder pain that interferes with daily activities. Pain at rest is a good sign that it's become pretty advanced. But as I said, probably the number one complaint is pain at night. A lot of times patients will be able to kind of function during the mid portions of the day. They have pain in the morning, pain before they go to bed, but at night they toss and turn and don't get a good sleep. I can tell you, as having a 4-month-old at home with my wife, not getting very good sleep over a course of months can be pretty debilitating. So that is probably the number one concern of what we really focus on. Patients will have loss of motion as well as weakness. And patients have tried some sort of conservative management, either anti-inflammatories, injections such as steroid injections into the shoulder, as well as physical therapy. So some basics about the shoulder replacement. The replacement is performed the same day in the hospital. And if someone's healthy enough, we're doing these in the outpatient setting now, where patients are having the surgery, going home the same day. The way we're able to do that is we focus on pain control. We give pain medicine when patients go home, but we also do a nerve block. That nerve block allows us to kind of take pain away from that shoulder for about 18 to 24 hours, sometimes up to 2 or 3 days, depending on what medication is used. We still put you to sleep during surgery, but when you wake up, at least you're not having any pain. The basic post-operative is that you're in a sling for 6 weeks while it's recovering. Now, the nice thing about that is you still have your legs, so it's unlike a knee and hip replacement where you can get up and walk around, so you can still be pretty active for the most part. We begin physical therapy pretty shortly after surgery, within a couple of days, just on your own, doing some basic passive range of motion where you're letting that arm kind of get just used to it a little bit. We start actually formal physical therapy about 2 weeks later, give a chance for some of the swelling to go down. Once you're off pain medicine, you can start driving. We always just say, just take the sling off, put it in the car seat next to you, and let your arm rest on the handle. So really, sometimes within 3 to 4 days, patients can drive if they're comfortable doing that. After everything's healed and the implants settled in, we start strengthening, which is about 3 months. And studies have shown that these improve up to 2 years later. So we see people consistently getting better over the course of the follow-up for the first couple of years. And at that point, most people are 80 or 90% better at least. So to kind of show the basics, to understand what a reverse shoulder replacement is, we really have to look at what an anatomic shoulder replacement is. An anatomic shoulder replacement simply recreates the ball and socket exactly as it is. And it's for a very specific type of patient. It's for patients who have a form of arthritis that does not damage the rotator cuff muscles. The rotator cuff muscles are those 4 muscles that go around the humerus. There's one in the front, one in the top, and 2 in the back. And they form a sleeve that goes all the way over the shoulder. That allows us to do all our overhead activities. So for a patient receiving an anatomic shoulder replacement, the rotator cuff muscles have to be intact. And they started noticing this in the 70s, is that they're putting this type of implant in everybody, but there's a certain subset of patients that were doing poorly, and those are patients who had the torn rotator cuff. And so, as I mentioned before, in the 70s, we started realizing that there's patients who, when you're looking at the x-ray, instead of that humerus being perfectly placed in the socket like a normal shoulder, it starts rising up. Because what happens is those rotator cuff tendons, when they tear, those muscles are no longer holding that ball in place. Because of that, the ball is shifting around trying to find its home, and it starts rubbing away. And the reason it gets pulled up is because the strong deltoid muscle is still intact. So the arm can still function, but as that deltoid muscle pulls the ball upwards and it hits another bone, you almost have to leverage off to get any motion. So we start losing motion, losing functions. This is a specific type of arthritis known as rotator cuff tear arthropathy. And these patients have classic symptoms such as they have torn rotator cuff tendons, they can't lift their arms. And if you try to put a normal anatomic shoulder replacement, like the picture in the bottom, it shows that there is loosening of the implant, loss of function. And although it might take the pain away initially, it's going to fail pretty quickly. So in the early 80s, a French surgeon came up with the really ingenious idea that's kind of changed the way we do shoulder replacements, of taking the ball and socket and turning it around. So instead of the ball being on the humeral, the long side of the arm, it goes on where the socket was. By doing that, the humeral side can now have a deeper dish. And by doing that, the main function that we look at the rotator cuff tendons is to stabilize the shoulder. By having a deeper cup to which we can put the ball into, we don't need the rotator cuff anymore. Because people always ask, well, if my rotator cuff's torn, do you need to fix it? With this implant, you don't need to fix it because it mimics that same function what the rotator cuff does. It holds the arm in the right position. So the big, strong muscles, such as the deltoid, the pectoralis major, the lat, all the big muscles that we see kind of bodybuilders working on all the time, that's the muscles that can still function just normally. So we get almost all of our function back of our arm because of that. And most importantly, pain goes away. And so, as I mentioned, the reverse total shoulder replacement relies on the deltoid muscle instead of the rotator cuffs to allow us to elevate our arm. And so this was developed in 1985 by that French surgeon, Dr. Paul Grammont. And for Europe, they used this for a couple decades. And it wasn't until 2004 that the United States actually started saying, we need to get this approved by the FDA to start using in America. The European data was really good. And so we need to start translating that into success in America. And since 2004, the past 16, 17 years, the complete design and function of the implant has changed pretty dramatically. It went from a long implant that took a lot of bone to a very small, compact implant that has dramatically improved the outcomes. Because of this, we really changed a lot of the indications for why we do reverse shoulder replacements. It used to be very limited to just patients who had torn rotator cuffs and arthritis, but now it's kind of expanded to patients who are having revision surgery, such as you've had a failed prior surgery, patients with any kind of major trauma to their shoulder, patients who are missing bone, because it's a stronger implant that has better fixation in the bones. And so, as I mentioned, the typical indications for patients with torn rotator cuff or torn rotator cuffs and arthritis, but it's also for patients who have failed a primary shoulder replacement. Studies have looked at patients who have replaced their primary shoulder replacement to another one. That hasn't done nearly as good as if they take that anatomic shoulder replacement and go to a reverse shoulder replacement. So this has been really a game changer for shoulder surgery and really patient pain relief in general, especially as we get into our later years, 60s, 70s, 80s, 90s. These have shown to have phenomenal outcomes. And when we get that CT scan that we mentioned for preoperative planning, different companies have utilized this to be able to improve the surgical outcomes. We now have computer programs that allow 3D imaging of your shoulder so we can get the exact sizes we want. From that, we can actually have implant or specific guides known as patient-specific instrumentation to be created in a laboratory, sent to either the hospitals or the surgery centers, so we can recreate the exact plan on the patient at the time of the surgery. And some of the newer technology that's coming around is such as virtual reality, where you can wear a headset, use that CAT scan that you had before surgery, and actually be able to have a 3D image of the shoulder while you're operating in your headset. So it can show exactly where you're putting all the implants and make sure it's perfect every time. So, I mean, this is a pretty significant improvement from where we were, even 5 years ago, but specifically 20 years ago. And those results were great then. And so the outcomes have been phenomenal for this. So the big question is we know you're a candidate because of what we mentioned before. And so how are the results? And most patients are significantly satisfied with the outcomes of this. Some studies have looked at, so how do hip replacements do and how do knee replacements do? About 90% of hip replacements are very happy and about 85% of knee replacements. Another study then took that same information and looked at shoulder replacements, and they found out that 97% of patients were happy with it. So very high success rate. And so, as we mentioned before, the next question I get is, well, how long do these last? Especially if the patient's a little bit younger in their 60s or 70s. Well, survival rate of these implants at 10 years is 90%. So 9 out of 10 implants is going to really last. And that was from older implants with older data. So as that's improved, that number is going to only go up over time. Good. And these are the two little guys that brought us back to Ohio. But so is there any questions at all? I think you're still muted.
Yep, good call. Good catch. Thank you. How bad does my arthritis have to be to warrant a total shoulder replacement?
It's really, I get that question all the time. I say the only nice thing about arthritis is it's on your time. I see some patients who have very mild arthritis, but the arthritis is in the exact spot to where it's rubbing that they need a shoulder replacement. And I see some patients who have severe arthritis that aren't ready for a shoulder replacement. The one nice thing about shoulder replacement, it's not a rush. So we can try anything we want to before: injections, physical therapy. Some people have a big trip they're coming up. They have a 40th wedding anniversary. Whatever it is, we can take the time to do the replacement once that person's ready. The main thing is that patient's going to tell me that it's time for it. And we know that because the symptoms have become severe. The symptoms can be either loss of function, loss of motion, or just debilitating pain and pain at night. So it's really we try to look at each patient individually. And I say, you're going to know when it's time because you're going to be almost asking for it because the pain will be severe enough.
What happens if the muscles have been damaged as well?
Well, and that's the amazing thing about the reverse shoulder replacement. So we can have significant damage, trauma, loss of bone, loss of muscles, and the reverse shoulder replacement, as long as we have that deltoid muscle intact, we can almost restore all the function just based on that muscle because of the design of the implant. The implant is what we call semi-constrained. That means our normal shoulder is the most unstable joint we have in our body. That's why it's the number one joint that we can dislocate. This shoulder replacement kind of stabilizes that shoulder to allow the muscles that are still intact to work. So that's exactly what the implant was designed for patients who have torn muscles.
Is there a lengthy period of therapy after the reverse total surgery?
That's another great question. Really, there's not a lot of the therapy is really just moving your arm on your own. So we do send people to therapy just so we have kind of a guidance to each stage we go through. We have really 3 phases. The first phase is just being in the sling, letting the swelling going down, letting the pain get under control. The second phase is moving your arm on your own, but really no weights at that time. The weight of your arm could still be 10 or 15 pounds. So using that to start off with, and then the final stage is strengthening. So at this point, a lot of patients are doing most of the physical therapy on their own with guidance from a physical therapist with occasional visits.
Thank you. Is reverse total shoulder replacement better than total shoulder replacement?
That's a great question. They both have their own specific indications. If a patient is a candidate for an anatomic shoulder replacement, meaning it's standard glenohumeral or shoulder joint arthritis with intact rotator cuff, then an anatomic shoulder replacement is just as good as a reverse shoulder replacement. But in situations where bone is missing, tendons are missing, then a reverse shoulder replacement has much better results and is more indicated. As patients get older and the risk of having a rotator cuff tear becomes higher, we start leaning towards a reverse shoulder replacement. The recovery is a little bit easier because we don't have to wait for the tendons to heal and we don't have to rely on those tendons. So for the exact indications, they're both great, but the reverse, when head to head in certain patients, can be much more beneficial.
Well, I guess that kind of leads into the question that I had, and I think you kind of answered it based on the symptoms. But can I choose which surgery I want to have?
It is. I think the biggest part of my job is to help guide a patient. There's no right or wrong answer. It's really what a patient wants. Sometimes we have the decision: do we want to try to repair a rotator cuff as we get older, or do the shoulder replacement, which might be an easier recovery? Probably the longest interactions I have in the office is sitting down with a patient, going over the pros and cons versus each surgery, kind of saying what I would do if I was in their situation, and trying to come up with a decision. Because for some patients, one solution that might be the quote unquote textbook decision might not be the best answer for that patient. So each patient has to have an individual choice based on their goals and their expectations with surgery. So I would actually rather a patient pick their own surgery to some degree, because they're coming at it with informed decision making, and so they know what they want and there's reasons for it. And I just kind of tell them, we kind of go through the pros and cons of that decision.
If the damage is due to several dislocations, not just arthritis, which replacement is best?
If the problem is instability, meaning the shoulder is unstable, the reverse shoulder replacement is typically better. The reason that is because with instability, the ball is popping out of the socket. With the reverse shoulder replacement, it stabilizes the shoulder. So for patients who who are older and have had a history of instability and their shoulder dislocating, the reverse shoulder replacement is the perfect answer for that.
Thank you. If the rotator cuff is not currently torn but has been in the past, is there a better of the two?
Yeah, that is something. If we start seeing damage to the rotator cuff, we start leaning towards a reverse shoulder replacement. The reason being is if it was torn before, there is a chance it could be torn again. But if a patient's younger, they have full strength with that rotator cuff, good range of motion, then I'll still lean towards the anatomic shoulder replacement. But in those situations, in addition to the CAT scan, I get an MRI. If the MRI, that tendon looks really healthy, and I think there's a very small chance it would ever re-tear, then I prefer to do the anatomic shoulder replacement. But if there's any question of degeneration of the tendon, inflammation, partial tears, then I'm going to lean towards a reverse shoulder replacement. And that's when patients' age starts coming into it. Because if someone's less than 50 and we think, okay, we want this implant to last 25 years, but there's a chance at some point you can have need another surgery. It's nice to have the anatomic because it's very easy to switch that from the anatomic to the reverse. So it really depends on the patient situation, but as long as that tendon looks great, we do the anatomic. If there's any question, we do the reverse.
Great, thank you. And both these next two questions, we can kind of combine them. They're based on return to regular activities. So how long after surgery will I be able to return to regular activities? And can I play golf after a total or reverse total shoulder replacement?
The second part, that is a great question that, especially this time of year, I get all the time. So the first question is really, can I return to my activities? It depends on what those activities are. If it's basic daily activities, within 2 to 6 weeks, you're kind of doing that. That's, housework, basic things like that. In terms of like working out, that's between 6 and 12 weeks. Activities such as tennis and golf, that's usually after 3 months. With golf, you can absolutely return to full golf. What I do is I usually have you start with putting at 3 months, chipping it at 4 months, iron at 5 months, and driving at 6 months. And really, it's you can progress through that as fast as you can tolerate, but that's just a generic guideline. Tennis can be a little bit more challenging because it's overhead, but people can do it. But golf, absolutely, because of the motion, people can. I have a lot of patients golfing. I tell them, if you miss a putt, you can still blame me. It might not be the shoulder's fault, but at least you can probably save a couple strokes that way.
Is the sling one?
Yep. He froze. Hmm. I don't know if you guys, I don't know if you guys can still hear me. If that's been canceled. You guys can type questions in though until it comes back. Hmm. Okay, perfect. So let's see that. So I think I'm still on. So, I'm going to answer some questions. So the first thing is a sling worn after the reverse total, and for how long? I do recommend wearing the sling for about 6 weeks. After 2 weeks, we have you start taking that sling off for basic daily activities. I have you wear the sling for 6 weeks at night and when you're in public. But after 2 weeks, you kind of start taking it off and using your arm for more basic activities, especially elbow range of motion. And then, so Tom, good to hear from you. Um, so the question is, with osteoarthritis, range of motion is limited. Reverse or anatomic at 66 with just arthritis, I know rotator cuff concerns, I would do an anatomic shoulder replacement. And the reason being is that if your strength is really good, it's nice to have the anatomic shoulder replacement because we have the opportunity to switch it anytime if we need to. So someone young, like 66, with good strength, I would prefer the anatomic shoulder replacements. And the follow-up question from Tom, are there limits to activities? So the answer, I don't put limitations on the shoulder replacement. You know, I always tell people to be smart with it. So when someone is doing daily activities, I don't want someone trying to chop wood with one arm or do one arm push-ups and pull-ups. But as long as you're doing things kind of where you don't feel a significant amount of pain or pushing yourself to the limits, then I would agree that you can still do daily activities. And so how about swimming or water exercises as part of therapy? Water exercises are the best type of therapy. You know, unfortunately, we used to do aquatic therapy for all types of rehab, you know, with the shoulder. You know, unfortunately, a lot of physical therapy centers quit having aquatic therapy. So we don't write for it as much, but water therapy is probably the best type of therapy we can have. I mean, you can just go in there, float, and it helps with the range of motion.
Thanks. My internet went down, so thanks for.
Yeah, I wasn't sure if I was still live. So
Yeah, you were, and my internet went down, so I apologize for that. But
no problem.
How many questions did you answer? Just another question there, or
Yeah,
two?
a couple questions.
So we just have a couple more here, and then we will wrap it up for the evening. So can a total and a reverse total shoulder replacement surgery be done outpatient in an ASC?
Yeah, well, we try to primarily do, if a patient's healthy enough to do shoulder replacements, either reverse or anatomic, they're both the same. I have one even tomorrow, that if we can do it at an ambulatory surgery center, they're safer from the standpoint that they're cleaner, so there's less chance of infection compared to a hospital. For the most part, the staff is very efficient and very comfortable with the procedures. So if as long as there's no contraindications, meaning there's nothing that's limiting a patient from going from an outpatient surgery, such as heart issues, lung issues, then we prefer to have it at an outpatient center. Now, the one caveat to that is that Medicare has not allowed outpatient total shoulders yet. They are this year coming out with it. They allowed hips and knees the last couple of years, and Medicare is usually just a little bit behind the times because they're run by the government. So they just kind of do one thing at a time. And now that the next step is shoulder replacements. So by next year, Medicare will be outpatient too, where the only limitation then is going to be any health issues the patient has. But the shoulder replacement, you can absolutely do outpatient.
And speaking of that, can you go home after surgery if you live alone?
You can. You know, the nice thing about shoulders is I had this conversation today in the clinic is that unlike your knees and hips where you're really limited in mobility, is that you can get up and walk around. You still have your other arm to use. So I have a lot of patients who go home the same day and or the day after surgery, depending, and they're able to take care of themselves because they still have their other arm. You can still use even your operative arm kind of below the waist to kind of help hold and support things. So most people get around pretty easily without, you know, we just want someone to have assistance for the first 18 to 24 hours, just as the anesthesia and medications are wearing off. But once you get beyond that time frame, not really much problem living at home by yourself. Oh, you're muted again.
Sorry. to wrap it up here, we did have this kind of ties in perfectly the question. So where do you do surgery? Which OrthoNeuro offices do you see patients at?
Oh, good question. So I do surgery at either New Albany Surgery Hospital. You know, it's really one of the best in the country. They're orthopedic centered hospital. I also do it at Grove City Methodist Hospital, kind of mirrored around that same image of having mainly orthopedics. Those are my surgery hospitals I go to. In terms of ambulatory surgery centers, I go to either Polaris Surgery Center or Pickerington Surgery Center. They're both Ohio Health. They're both fantastic, very similar, very good anesthesia. One's just north of the city, one south of the city. It's more just for patient convenience, but they're both phenomenal.
And then one of the attendees this evening, Paul Costiu, you repaired both of his shoulders for torn rotator cuff and bicep tears. He's still having some pain, though I can do routine activities and golf. Should he come back in for a checkup?
Absolutely, Paul. Would great to see you. Our goal after any kind of surgery is to get 80% better. And if we're below that, we definitely want to take a look at it because worst case scenario could be something very small that either some exercises, an anti-inflammatory injection can take care of, or if there is a chance that a rotator cuff is retorn, we want to know. The earlier we know, the better we can effectively treat it. So we'd love to see you back.
Okay. Wonderful. Thank you so much for your time this evening, Dr. Stevens, and thank you everyone for joining us this evening and for participating in tonight's webinar. Our next webinar will be held on June 2nd. Dr. James Cassandra, orthopedic hand surgeon, will speak on carpal tunnel syndrome. Thank you, everybody. Have a good evening.
Hey, great to hear from you guys, and a lot of familiar names out there. So it's good to see you, Paul, Tom, and Rick. So I hope you guys are doing really well.
Thank you,
Talk
Dr.
to you guys
Stevens.
later. Bye.